Today, FDA approvals in multiple myeloma, neuroendocrine tumors, and of a biosimilar, a priority review designation in ovarian cancer, a partial clinical hold lifted in multiple myeloma, and encouraging findings in a lung cancer trial. Welcome to OncLive News Network. I'm Kristi Rosa. The FDA has approved the combination of daratumumab with lenalidomide and dexamethasone for the treatment of patients with newly diagnosed multiple myeloma who are ineligible for autologous stem cell transplantation. The approval, which was granted through the agency's Real-Time Oncology Review pilot program, is based on findings from the Phase 3 MAIA trial, in which the daratumumab regimen reduced the risk of disease progression or death by 44% in this patient population versus lenalidomide dexamethasone alone. The open-label, multi-center Phase 3 MAIA trial included 737 newly diagnosed patients with multiple myeloma who were ineligible for high-dose chemotherapy and ASCT aged 45 to 90 years old. At a median follow-up of 28 months, results showed that the median progression-free survival for DRD had not yet been reached, versus 31.9 months for patients who received RD alone. Moreover, DRD led to deeper responses versus RD alone, including higher rates of a complete response or better at 48% versus 25%. The overall response rate was also higher with the triplet regimen at 93% versus 81% respectively. The FDA approved a pre-filled syringe for lanreotide, which has been designed to enable healthcare providers to more easily administer the injection for the treatment of adults with unresectable, well or moderately differentiated, locally advanced or metastatic gastroenteropancreatic neuroendocrine tumors. The indications for the treatment remain the same as that of the previously approved pre-filled syringe. It is also indicated for use in the long-term treatment of patients with acromegaly who inadequately respond to surgery and/or radiotherapy, as well as for those who are not candidates for surgery and/or radiotherapy. The pre-filled syringe can be used as a means to improve progression-free survival in adult patients with carcinoid syndrome to reduce the frequency of short-acting somatostatin analog rescue therapy. In an effort to understand the way the syringe was being used in clinical practice, as well as identify ways in which features of the device might be improved, investigators launched 5 complementary studies in partnership with patients, their caregivers, nurses, and other healthcare professionals. The feedback from these studies informed the redesign for the syringe, which was envisioned to increase the grip on the product and thus make it easier to administer the injection. Lanreotide was originally approved for the treatment of patients with unresectable, well or moderately differentiated, locally advanced or metastatic GEP NETs in December 2014. The FDA approved the bevacizumab biosimilar PF06439535, known by the trade name Zirabev, for the treatment of patients with metastatic carcinoma of the colon or rectum, unresectable advanced metastatic or recurrent non-small cell lung cancer, advanced and/or metastatic renal cell cancer, and persistent recurrent or metastatic carcinoma of the cervix. The approval is based on findings from a comprehensive data package, which demonstrated biosimilarity of PF06439535 to reference bevacizumab. This includes results from the Reflections B73910003 trial, which showed clinical equivalence and found no clinically meaningful differences between the biosimilar and bevacizumab in patients with advanced non-squamous non-small cell lung cancer. As part of the Reflections clinical trial program, the biosimilar has been studied in nearly 400 patients to date. The agent was previously approved for use in the European Union. The FDA has granted a priority review designation to a supplemental biologics license application for the PARP inhibitor niraparib for the treatment of patients with advanced ovarian, fallopian tube, or primary peritoneal cancer who have been treated with 3 or more prior chemotherapy regimens and who have either a BRCA mutation or have homologous recombination deficiency and progressed at least 6 months after the last platinum-based chemotherapy. The designation is based on findings from the Quadra study, in which the overall response rate was 28% in the primary efficacy population of patients who had HRD and who received at least 3 prior lines of therapy. Results of a post-hoc analysis of Quadra from the BRCA mutant cohort, which comprised patients who were also PARP inhibitor naive, showed that the ORR was 29% in this subgroup. The response rates were similar between those with germline and somatic BRCA mutations at 25% versus 33% respectively. The FDA must make a decision on the application by October 24, 2019. In multiple myeloma, the FDA has lifted a partial clinical hold that was placed on the Phase 3 CANOVA study, which is examining venetoclax in combination with pomalidomide and dexamethasone in patients with relapsed refractory multiple myeloma that harbors 1114 translocation. The lift on the partial hold is based on an agreement on revisions to the CANOVA study protocol, which includes new risk mitigation measures, protocol-specified guidelines, and fully updated criteria. However, the lift does not apply to other clinical trials evaluating venetoclax in multiple myeloma, while next steps continue to be addressed with the FDA. The agency previously placed a partial clinical hold on all studies that are evaluating the BCL2 inhibitor in patients with multiple myeloma. In the Phase 3 Bellini trial, bortezomib and dexamethasone combined with venetoclax or placebo in patients with relapsed refractory multiple myeloma, a higher proportion of deaths was observed in the venetoclax arm compared with the control arm of the trial, and 45 patients died due to progressive disease. The combination of durvalumab with standard etoposide and platinum-based chemotherapy demonstrated a statistically significant and clinically meaningful improvement in overall survival compared with standard chemotherapy alone as a first-line treatment in patients with extensive-stage small cell lung cancer, meeting the primary endpoint of the Phase 3 Caspian trial. The safety and tolerability findings of the immunotherapy-chemotherapy combination were consistent with the safety profile of each agent alone, and full findings of the study will be presented at an upcoming medical meeting. In the international multi-center open-label Caspian study, 988 treatment-naive patients with extensive-stage small cell lung cancer were randomized to durvalumab plus etoposide and either cisplatin or carboplatin, durvalumab plus the CTLA-4 inhibitor tremelimumab and chemotherapy, or chemotherapy alone. Durvalumab is currently approved by the FDA for the treatment of patients with locally advanced, unresectable stage 3 non-small cell lung cancer who have not progressed following chemoradiotherapy. This week, we sat down with Dr. Naval G. Daver of the University of Texas MD Anderson Cancer Center to discuss how to decide a frontline treatment for patients with newly diagnosed acute myeloid leukemia.
The most difficult challenges in managing patients with acute myeloid leukemia are identification of appropriate prognostic and targeted markers that can be quickly available so we can use targeted and immune therapies in an appropriate way. We now have a number of drugs that are showing great efficacy, such as the FLT3 inhibitors, including midostaurin, gilteritinib, and quizartinib, as well as IDH inhibitors and new monoclonal bispecific antibodies. But the key is to select the patients who will have the maximum benefit for these treatments, and that requires rapid molecular sequencing data, access to these drugs in a quick approach, as well as doing combination therapies, which are showing much better activity in combination rather than single agent approaches. So a lot of these things are moving, but we see there's a big difference between the large academic centers that have been involved in the trials where sequencing and immune results come in within 2 to 3 days versus community hospitals or even smaller private practices where it may take 8 to 10 days, and then often the patients miss the opportunity to get these effective targeted immune therapies. The biggest way patient factors influence decision making is differentiating between what we call high intensity therapies and lower intensity therapies. Historically, we used to use high intensity therapies very frequently because the response rates with high intensity regimens such as 3+7 or FLAG-IDA are much higher than used to be with the historical low-intensity therapies like azacitidine, low-dose cytarabine. We would see response rates of 70 to 80% with high-dose chemo versus 20 to 30% with low-dose therapy. And so people would be much more inclined to do high-intensity therapy unless the patient really were above 75 or very poor candidate for other comorbidities. Now the gap has actually become much smaller. So what we call lower intensity therapies such as azacitidine with venetoclax or low-dose cytarabine with venetoclax or hypomethylating agents in combination with some of the FLT3 inhibitors are actually showing response rates in the range of 60 to 70%. So almost as good or maybe even as good as we would get with high intensity therapy. Now we don't have enough durable follow-up and survival endpoints, but it is becoming a much more intricate process, and patients are now involved where we may have a 70-year-old or 65-year-old who could be a candidate for intensive chemotherapy, but with a lot of risks, a lot of toxicities, long stay in the hospital, high early mortality of 15 to 20%, and that same patient may be able to get azacitidine venetoclax or other low-dose therapies with an equivalent response rate, maybe with a similar survival, with a lower early mortality, less days in the hospital, less toxicity. And so I think we are now presenting these options to our patients, saying that these are newer, we don't have as long follow-up, but these are probably good considerations. And then the patient will say, you know, no, I want the tried and tested thing, the one that has the best track record, transplant, high, you know, I want to go for the cure. I don't mind managing toxicities. If I have to be admitted, that's okay. That's my end goal. And many will say, you know, no, if you can get me a few years, if you think this has a high response rate, you know, I can spend more time outside the hospital with my family, with friends. That's what I want. And we actually do see that there's not one answer. Patients have very different goals of what they expect and want, even patients who are 65, 70 years of age.
That's all for today. Thank you for watching OncLive News Network. I'm Kristi Rosa.